Hello, students. Welcome to BSN 720. Today's topic is bleeding conditions. I have listed the learning objective. Please go through that. And then there is a little bit of a review of the hematological system, which you have already learned in your previous physiology classes. So just review that to get an understanding or refresh your memory. Then there is a list of blood values or lab values listed. The expectation is you go through that and understand it and learn it. And then we're going to look at different disease condition related to this hematology system or blood coagulopathies. So before that, we need to know what hemostasis means. Hemostasis involves the vascular endothelial layer, that is the innermost layer of the blood vessel, platelets, coagulation factors, which normally function together to obtain or stop hemorrhage and repair the blood vessel. That's what hemostasis means, and our body undergoes changes whenever there is a cut or a bruise or bleeding, and this process will be attained. Now, let's look at different type of coagulopathies. I skipped a slide which is about vitamin K deficiency, which we're going to learn in detail later in the class. So there are two different type of coagulopathies. One is inherited, which is usually a genetic disorder and a deficiency or dysfunction of a specific clotting factor. A good example is hemophilia. The difference between inherited and acquired coagulopathies, in inherited one, there is usually deficiency of one clotting factor and it's usually diagnosed earlier in their childhood. But in acquired condition, this develop as a result, secondary condition as a result of another underlying medical condition or a pathology. And there are multiple clotting factors missing at that point, and also usually associated with any type of disease condition. Sometimes people become septic and then they have coagulopathy. Sometimes when during a burn trauma, they can develop coagulopathy. So it could be as a result of an underlying pathology. Now, let's look at the first one. We're going to learn about vitamin K deficiency in detail, so let's skip that. The first inherited condition I'm going to discuss is hemophilia A and hemophilia B. So, hemophilia is an X-linked recessive genetic disorder. That means usually the female children are the carriers and the male person will express the disease condition. So hemophilia A, there is deficiency of factor 8. But in hemophilia B, the difference between the two is the factor 9 is missing, or there is deficiency of factor 9. Hemophilia A constitute about the majority of the cases, at 80% of the cases. B is comparatively lesser compared to hemophilia A, and also it's called Christmas disease because it was first diagnosed in a Canadian boy. His name was Stephen Christmas. So just an interesting fact. That's why it's called Christmas disease. And I think it was first diagnosed in 1952. So 80% of the population or cases are hemophilia A, and B constitute about a small percentage of it. There is another disease condition called von Willebrand's disease, which is deficiency of von Willebrand protein, which is kind of the factor needed for factor 8. So it is also a type, we can say a type of hemophilia A, because the deficiency of that protein results in dysfunction of the factor 8. So again, it's classified as a different disease just for the treatment because they can actually replace that von Willebrand protein itself. So this is more in Canada. One in about 1,000 Canadians have those conditions. So it's very prevalent. So that's the difference between the three types. And it's just talking about that. What do we see as clinical manifestation? So clinical manifestation and complications include very slow, prolonged bleeding from minor trauma and small cuts. And then sometimes there is delay bleeding after minor injuries. Patients might have like uncontrollable hemorrhage after like a small procedure like dental extractions. The bleeding would not stop. Epistasis, ecchymosis, and subcutaneous hematomas, neurologic changes like paralysis could develop if there is hemorrhage or hematoma in the brain. And the biggest complication of this is hemarthrosis, bleeding into the joints, and which eventually lead to joint deformity, and it's extremely painful. So this would result in like deformities of knees, elbows, ankles, etc., that affects their posture and their mobility. Usually diagnosed in childhood because uncontrolled bleeding, and then we do further investigations and find out. The treatment is prevention of and treatment of bleeding. Replacement of the clotting factors is a primary means of supporting patients. So nowadays there are a lot of very good treatment available, or these clotting factors are replaced. For hemophilia A, factor 8 replacement, there are different products like Zonavate is one of the common product we use, and Humate P, which you will see is used a lot in our practice, which is factor 8 in von Willebrand protein. So these are some of the products we use, and factor 9 replacement is Benefix. You don't have to memorize the names, but you just have to learn that the factor 8, factor 9, and von Willebrand protein can be replaced, and that is the treatment for this. Other treatment involved is to decrease bleeding, or DDAVP, which is desmopressin, which is antidiuretic hormone. Um, so this can actually stimulate and increase the factor 8 in von Willebrand factor. So we administer that, and it has very short action, and it's usually given as sometimes as nasal spray, or there are different varieties of the product available, but the easiest one is nasal spray. And what it does is it prevents bleeding. Antifibrinolytic therapy is also to help with the bleeding or prevent bleeding. One of the common example is tranexamic acid, which inhibits fibrinolysis by inhibiting the plasminogen activation. So in a fibrin clot, so that enhances stability of the clot, and it prevents bleeding. And you might have heard about this drug, tranexamic acid. In case of major bleeding, sometimes we give that. It can be given as an oral pill, or as an IV infusion, depending on the severity of the case. So these are the two drugs commonly used. This is a picture of a large hematoma in case of hemophilia. Now, let's look at one of the acquired conditions. So, some of the acquired conditions are liver disease, vitamin K deficiency, disseminated intravascular coagulation, of which we're going to learn about cirrhosis first. So, cirrhosis is a progressive condition of the liver, or we can say that cirrhosis is a final stage of chronic liver disease. When we call it cirrhosis, it has advanced, or it's end stage. It is usually characterized by the scar tissue or fibrosis formation inside the liver. You know that liver tissues are regenerative. So initially with smaller injuries, the liver tried to regenerate itself. Finally, chronic inflammation and scarring leads to changes in the complete liver architecture, or all the cells are destroyed. This lead to cirrhosis, or the final stage of this chronic liver disease. It's a picture. So, when we look at the causes, we've always linked liver disease to use of alcohol. Alcohol-related cirrhosis is the commonest type of cirrhosis found or diagnosed. But there are also other type of cirrhosis. So in case of chronic hepatitis C and chronic hepatitis B, patients can develop cirrhosis. Certain non-alcoholic fatty liver disease, because there is excessive fat accumulation in the liver, which causes like inflation of the cells and fat deposit in between the cells, which lead to scarring and eventually death of the tissues in the liver. That's called non-alcoholic fatty liver disease, or it eventually leads to something called NASH, non-alcoholic cirrhosis disease. So that can affect, that is one of the causes in some cases of severe right-sided, non-treated right-sided heart failure, chronic congestion of the blood vessels, or blood goes from superior and inferior vena cava into the right side of the heart. So when there is congestion, when there is right-sided heart failure, the inferior vena cava blood return is affected. So it causes congestion of the liver. So if we don't treat right-sided heart failure, it eventually lead to congestion in the liver and cirrhosis, which is called cardiac cirrhosis. So there are, depending on the cause, it could be classified into different types. So, what are the clinical manifestation? Earlier stages, we don't see much symptoms. It's all vague symptoms and abdominal pain, fatigue, dyspepsia, weight loss, enlargement of liver and spleen, nausea, vomiting, weakness, muscle loss, etc. So, these are all a combination of vague symptoms. But in the later stages, two things happens: liver failure and then portal hypertension. This causes all the complications in the later stage. We're going to look at that in detail. There is a picture with all the signs and symptoms. When you learn it from head to toe so you don't miss the system, but we're going to learn in detail about this. Okay. So late symptoms usually, so if we can divide the cirrhosis into compensated liver failure and decompensated cirrhosis. In compensated, the body itself or liver itself try to compensate and you don't see much of the symptoms, but in decompensated cirrhosis, that is the end stage and there's irreversible changes happening. So first and foremost is jaundice. It could be minimal or severe depending on the extent of the liver damage. Patient appear jaundice usually at the later stages of cirrhosis, and also they have severe pruritus. Pruritus means itching, and that happens because of accumulation of this bile salts under the skin. So when jaundice patients always are really itchy because of that reason, they have bile salts getting deposited under the skin, which causes severe itching. So these are the signs and symptoms. Second one is skin lesions. Liver, one of the functions of the liver is to metabolize the steroids, estrogen, androgens, testosterone, etc. in our body. Because of the dysfunction of the liver, there is excessive floating estrogen in the body, which causes spider angiomas. These are like red elevated blood vessels, which you can see, which branches out, and it happens in on the like cheeks, upper trunks, everywhere in the body. Another name for the spider angiomas are telangiectasia. You don't have to learn the name. You can just learn spider angiomas. You will hear if you are interested in learning the fancy name, it's otherwise called telangiectasia. And then other things which we would see is redness in the palms and the extremities or palmar erythema. These are all related to excessive estrogen circulating in the blood, and then liver cannot metabolize it. Hematological changes, you usually see thrombocytopenia, leukopenia, and anemia. So thrombocytopenia is because one of the thrombopoietin is produced by the liver. So liver cannot produce enough thrombopoietin. So it causes thrombocytopenia, anemia, usually as a result of inadequate red blood cell production because of poor diet or poor absorption, deficiency of folic acid, etc. And also, one of the complication of liver disease is bleeding. So that can also lead to anemia. As we said before, we see endocrine problems because all these hormones, steroid hormones, estrogen, testosterone, all of that are metabolized by the liver, and that functionality is lost. Peripheral neuropathy, basically because of deficiency of vitamin B12, folic acid, thiamine, etc. Peripheral edema and ascites happens as a result of reduced production of albumin by the liver. So there is reduced albumin, which lead to decreased oncotic pressure of the blood vessels, which leads to increased pressure in the portal system, and also like sweeping of the blood into the third spaces, which usually is presented as edema or ascites, etc. So all of these manifestations are related to low level of albumin in the blood. This is an example of an ascites. Portal hypertension is one of the biggest complication of liver cirrhosis. It is characterized by increased venous pressure in the portal circulation. Also, so manifestations would be hepatomegaly, splenomegaly, systemic hypotension, and esophageal varices. So this our body, the gastric circulation or the mesenteric circulation and portal circulation are connected. So whenever there is high pressure in the portal system, in the GI system, it will manifest as esophageal or gastric varices because there is congestion in that circulation too. As a result, we can also see that patients develop hemorrhoids. They might have this feature called capomedusa, which usually we see in pregnant ladies. There are varices around the umbilicus. All of this are related to the internal hemorrhoids. All of this are related to congestion in the gastric circulation. Because of high pressure in the portal circulation, it affects the other circulation too. So these are the signs and symptoms, and esophageal or gastric varices are a medical emergency if it bleeds out. So that's what you're closely monitoring your patient for who are have cirrhosis, because they could bleed out anytime and that become a medical emergency. Complications, we're going to look at each one of them separately. First one is hepatic encephalopathy. Hepatic encephalopathy happens as a result of accumulation of ammonia in the blood. So protein, end product of protein metabolism, ammonia is converted into urea in the liver. So this conversion does not happen as a result of impaired hepatic cells, and this results in accumulation of ammonia in the blood, which causes excessive sedative effect, which is called hepatic encephalopathy. Ammonia can also cross the blood-brain barrier and cause neurologic toxic manifestations. So the hepatic encephalopathy is one of the end-stage manifestations of liver cirrhosis or complications of liver cirrhosis. Another common feature is hepatorenal syndrome. What happens in this case is that because of the lack of systemic circulation, there is reduced arterial blood flow to the renal system, which causes kidney damage. And that is so renal failure resulting as a result of cirrhosis or liver failure is called hepatorenal syndrome. So those are the biggest complications we will see in the two systems. We also didn't talk about the other complications, right? Yeah, we missed a slide, I think. Asterexes or flapping tremors. So, in case of fine tremors, sometimes which happens with certain drug withdrawal, etc., um, if you ask a patient to hold a paper in their palms, you can see that those paper is slightly moving. But asterexis is flapping tremors. You can see those tremors from a distance, and it's like very noticeable. Uh, Feeder hepaticus is that ammonia breath as a result of accumulation of byproducts. It causes a particular type of breath called feeder hepaticus or ammonia breath. What other complications did we miss? So we talked about cerebral depression, which is hepatic encephalopathy, could cause reduced blood supply or congestion, causing constipation, dehydration, hemorrhage, etc. Electrolyte imbalance, the common one you see is hypokalemia and hypocalcemia. Um, and there is hypovolemia because the fluid is swept into the interstitial spaces. Infection, because liver also has the function of providing immunity, or it helped in the formation of immune cells, or help in the immune system. So low immunity is a common feature of liver failure. So patients are prone to infection. And uremia, that is the complication of liver failure. So we talked about all of that. Now let's look at the lab studies or the diagnostic test. Usually in liver failure, liver function tests are elevated. So liver function tests involve your AST, ALT, ALK phos, GGT, all of those values will be elevated in case of liver failure. One thing to notice though, towards the very end stage of cirrhosis, you might notice all these values are normal. The reason for that is the number of cells, functioning cells in the liver decreases, so it cannot produce enough enzymes. So it appears normal, but it's not normal. So earlier stage of liver cirrhosis, you'll see that all these if we divide it into four stages, stage 1 to 3, you will see that the liver function tests are highly elevated. But towards the end, very end, it might be just appearing normal just because there is not enough liver cells to produce those enzymes, just to keep something in mind. Total serum protein and albumin, all of that will be reduced. Prothrombin time, INR, all will be elevated. When we do CBCs, we see thrombocytopenia, leukopenia, and anemia. Stool for occult blood could be positive if there is GI bleed. So, definitive diagnosis of liver cirrhosis is liver biopsy. That is the only way to find out how much liver cell damage has happened. So, that is the gold standard for diagnosis of liver cirrhosis. So these are the lab values, go through that. Our care involve preventing the factors which has caused all these problems, basically avoidance of alcohol if that is the cause, aspirin, Tylenol, non-steroidal anti-inflammatory drug, or the NSAIDs. All of this are particularly damaging to the liver, so to avoid all of those medications. Aside is in fluid overload, we can manage it with sodium restriction and diuretics. And paracentesis is a procedure where a catheter is inserted to withdraw fluid from the abdominal cavity. This is not a good procedure to do because it can cause spontaneous bacterial peritonitis, which is a complication. It can cause an infection because it's an external catheter, but it helps to relieve the pain and pressure to a certain extent, or shortness of breath to a certain extent. This can also cause fluid volume shift. So if we're removing large amount of fluid through paracentesis, it could cause like fluid electrolyte imbalance or shift in a quick time period. That is why most of the cases you would see patients who undergo paracentesis get albumin infusion to compensate for that. And you usually give the 25% albumin. Now, gastric or esophageal varices are medical emergency if they start to bleed out. So our biggest goal is to avoid bleeding or hemorrhage. The medication we commonly use are octreotide or sandostatin, vasopressin, and beta blockers. Um, so when you are caring for a patient with liver cirrhosis, you would notice that their blood pressure is always, systemic blood pressure is always on the low side, but they do have portal hypertension. And the beta blockers are to treat the portal hypertension. So you're coming in on a day shift and your patient's blood pressure is only like 100 over 60, you will never hold that medication just because if you hold it, they could have more venous congestion in the GI tract and cause bleeding. You don't want to do that. And you notice that patients usually are on either propranolol, nadolol, all of those medications are beta blockers. So never hold that medication in case of cirrhosis patient. It is used to treat the portal hypertension. Other management for esophageal varices are sclerotherapy, ligation of the varices, balloon tamponade, etc. The common procedure we do is banding or ligation of the varices. Sclerotherapy is injection of a sclerosing agent into that varus and it just sloughs off eventually. So this is a picture of the balloon tamponade. So a balloon catheter is inserted and the balloons are inflated and it helped to reduce the size of the varices. Um, then supportive measures for acute bleeding is fresh frozen plasma, packed blood cells, vitamin K, PPIs that are common medications are lansoprazole, pantoprazole, etc., lactulose. So here we are giving lactulose to draw the ammonia out of the gut. This is not for constipation. So in case of liver cirrhosis patient, never hold their lactulose. It might be ordered as like give lactulose 3 or 4 times per day as a patient having 2 to 3 or 3 to 4 bowel movements per day. Even though your patient has diarrhea, do not hold the lactulose. We want them to have diarrhea. We are inducing that diarrhea to get rid of the ammonia from the gut. So that is the significance of lactulose. I wanted to share a story of a patient. We had an elderly patient who had liver cirrhosis, and his wife was a caregiver. And the sad story is that had so much caregiver burnout that she somehow figured out this lactulose would get him to hospital. So she would hold his lactulose, and then he become unconscious, and then he would come to the hospital, and then we'll give him the lactulose, and he'll be like, "Oh, hello again." He'll wake up. So uh, it's just, I'm just saying that to click the fact that do not hold the lactulose. It is the medication that draws that ammonia out of the gut. Norfloxacin, certain antibiotics like norfloxacin, rifaximin, which is found to be effective in reducing ammonia. We don't know the exact mechanism of action. I've checked with the gastroenterologist once and he said, well, we don't know the exact mechanism of action, but it helps. So it helps. So long-term management, again, beta blockers, sclerotherapy, or ligation of those viruses, that's really, really important. And as nurses, it's important to watch also. Sometimes patients would have severe vomiting and they throw up the band. So make sure you watch for that too. Um, and any bleeding episodes. Those are the things. Non-surgical procedures, sometimes we create a shunt between the systemic and portal venous system just to decompensate or to reduce the venous congestion. So I will show you a picture of that. This is not to, this does not cure the cirrhosis. It just helps to resolve that portal hypertension, just a little aspect. So we have already discussed about that lactulose traps ammonia in the gut, and usually it can be administered as an enema or via the NG tube if your patient is unconscious or not able to tolerate it orally. If we're giving it as an enema, make sure it's given as a retention enema because it stays in the gut for a certain time period to draw that ammonia out. Antibiotics like rifaximin is also used. I don't know the exact mechanism of action. And be compliant with the medication therapy. Nutrition, when we look at that, we need high calorie diet, but we give restricted protein because ammonia is a byproduct of protein metabolism. So we don't want ammonia to accumulate in the blood, and the liver is not able to detoxify that. So our target is 1.2 to 1.5 gram per kilogram body weight per day. Nursing management, you can read about all of this, like treating alcoholism, hepatitis. I said hepatitis B and C are linked to cirrhosis. So, hepatitis B, we can give vaccination. Hepatitis C, we do surveillance and monitoring. Stress the importance of adequate nutrition because malnutrition can actually trigger liver cirrhosis. So it's important that if patient has a risk factor, we advise them to make sure of optimal nutritional status. Then right-sided heart failure, if a patient developed that, to treat it as early as possible so it doesn't cause any venous congestion in the liver. So those are the management. This is all the things we have already talked about. Paracentesis, uh, monitor for electrolyte imbalance. Paracentesis, they usually remove a large volume of fluid from the abdomen, which can cause fluid electrolyte shift. So that is something we should be watching for. And also monitoring the dressing for any blood or any leakage. And you will see that they might have some leakage because the abdomen is so distended. Abdomen is so, excuse me, abdomen is so distended and it causes so much trouble. Skincare, turning schedule, ROM exercises, deep breathing, and coughing exercises. These are all important in nursing management. One of the things we should always keep in mind is the patient will be on some type of diuretic therapy, so it causes alteration in electrolytes. Hypokalemia is one of the complications of this disease. So watch for the cardiac arrhythmias, hypotension, tachycardia, muscle weakness, etc. Hypokalemia also causes abdominal distension. And because potassium is required for maintaining the muscle tone, usually hypokalemia causes muscle weakness. So you might have heard about this. When patients have diarrhea and vomiting, one of the clinical features are abdominal distension. And you might think, oh, they just evacuated their gut, and why should they have abdominal distension? That's because of hypokalemia. It causes muscle weakness or it loses the tonicity of the muscle. So patients will have abdominal distension with hypokalemia. Observe for bleeding, that's our biggest goal. And so make sure you give the lactulose and the medication as per the. So I think that is about the cirrhosis, and learn that this is really important topic. And we would have a lot of questions from that. Now, let's look at some of the acquired other abnormalities commonly found. One is disseminated intravascular coagulation. So, disseminated intravascular coagulation is a bleeding and a clotting disorder. It affects both the bleeding pathway and the coagulation pathway. So, this results in the term itself, disseminated intravascular coagulation, you might think that the blood is clotting, right? But it is also characterized by profuse bleeding resulting from the disruption in the clotting factors. And so it's not just clotting, bleeding is also happening at the same time. This is a picture of petechiae. So what happens in the pathology here is that activation of coagulation pathway will result in thrombosis. Okay, the circulating thrombi will go and occlude minor or small blood vessels, causing micro thrombus in microcirculation level. Then fibrinolysis happens in the microcirculation. So fibrin degeneration happen, which causes bleeding. So one activates the other. So a coagulation pathway where both the bleeding and the thrombus formation pathway is activated. So microvascular thrombosis will be manifested as ischemia, gangrene. In the renal system, it could cause renal failure, necrosis, acute tubular necrosis, which is a type of renal failure, respiratory distress syndrome, paralytic ileus, etc. In hemorrhage, we could see intracranial hemorrhage, those petechiae, ecchymosis. Petechiae, small patches of blood vessels or spots. Ecchymosis is more like bleeding into the subcutaneous tissue. Hematuria, hemoptysis, all kind of bleeding will be seen in that. So both of this happens at the same time and it becomes extremely tricky to treat. Etiology, if you look at it, almost a lot of complications or disease condition can cause this complication. Like any type of cancers, patients are at risk for developing DICs. Any hemolytic process, patients are at risk for DICs. Transfusion mismatch, gynecologic conditions like abruptio placenta, amniotic fluid embolism. HELP syndrome is usually seen in eclampsia and preeclampsia when they have high blood pressure. This is a complication of eclampsia. So in all those cases, you would see DICs like sepsis, septicemia, shock. There are multitude of conditions like snake bites, transplant rejection. All of this can trigger that coagulation pathway. That's what it means. Our goal is to identify the signs and symptoms as early as possible. So your patient who is septic is developing pallor, petechiae, purpura, or they have oozing of blood, hematomas, something like that, you should clue in to see whether they are going into DIC. So that is our role. Respiratory system, you'll see hemoptysis, orthopnea, tachypnea, tachycardia, hypotension, GI bleeding, hematuria, and even in neurologic assessment, if there is any signs of intracranial bleeding, or is there any bleeding into the joints or something like that. Thrombotic manifestations you commonly notice is ischemia and necrosis of the extremities. A patient could develop acute respiratory distress syndrome, ECG changes, abdominal pain. So a lot of vague symptoms of bleeding and clotting can be found. You can also look at their lab values very closely and find out if they are going into DIC. So the prothrombin, partial thromboplastin, activated partial thromboplastin time will be all prolonged. The clotting factors like fibrinogen, platelets, etc. will be reduced. So all the times will be prolonged, but the factors will be reduced. D-dimer is like D-dimer, we check the fibrin fragments. So that means there is some sort of bleeding or clotting happening in the body. So it's not very specific, but it's linked to blood clotting. So if that is elevated, that's a significant sign. What else? Plasminogen, tissue activator, all of this will be reduced. All the factors will be reduced, but all the times will be elevated. That's one way of finding out. Management depends on treating the underlying cause because we cannot fix this problem unless we fix their underlying cause. So basically, diagnosing it quickly and stabilizing the patient, oxygenation and volume replacement, treating the underlying cause, and then supportive measurement with platelets, cryoprecipitate. So platelets replace platelets. Cryoprecipitate is the replacement of fibrinogen. Fresh frozen plasma has multiple clotting factors, so that's one of the it's like a blanket treatment. It kind of fixes most of the clotting factors. So if we're worried about multiple clotting factors, we will give them fresh frozen plasma. If we're worried about less fibrinogen and bleeding happening, then we give cryoprecipitate. If we're worried about low platelets, then we replace it with platelets. That's how we treat it. Now let's look at the next one, which is vitamin K deficiency. So vitamin K is required for the synthesis of clotting factors 2, 7, 9, and 10. So any deficiency in vitamin K as a result of malnutrition, malabsorption, prolonged antibiotic use, warfarin therapy, liver disease, you will see deficiency of all those clotting factors. Remember I said in the beginning, when we have an inherited disease, they usually have one clotting factor missing, but if they have an acquired condition, their multiple factors are missing. So in this case, that is what is going to happen. But one way to identify vitamin K deficiency, their platelets levels would always be normal. There's nothing wrong with the platelets, but their PTT, INR, PT, everything will be elevated. So that's a way to find out if it is vitamin K deficiency or not. Clinical manifestation, again, you will see all kind of bleeding. Management is administering vitamin K and fresh frozen plasma. Remember I said fresh frozen plasma is given when there is multiple deficiencies of clotting factors. So prolonged PT with normal platelets, vitamin K deficiency. Oh, there is this chart which tells you. So if there is factor 8 deficiency, we can give them factor 8, factor 9 deficiency, we give that factor 9. Multiple factor deficiency, give fresh frozen plasma. Low fibrinogen, give cryoprecipitate. Vitamin K deficiency, either FFP or fresh frozen plasma or vitamin K. So read those. This is important. That's important to know what to treat with, right? Okay, more acquired condition. The last one is massive transfusion associated coagulopathies. What happens in massive transfusion is that we're giving like maybe about 10 units of blood or more to a patient as a result of massive hemorrhage. So most of the hospitals will have this massive hemorrhage protocol or MTP, more massive transfusion protocol. They name it according to their wish. Um, anyway, it's called massive transfusion protocol or massive hemorrhage protocol. And it's always announced overhead, and the blood bank will get ready with all the blood available to that one particular patient who has that massive hemorrhage. And sometimes hospitals or organizations get notifications ahead of time when the ambulance is bringing a massive trauma, they will already initiate that massive transfusion protocol. We're going to learn this later too about the transfusion reactions. But in a nutshell, what happens is that because of that excessive transfusion, the clotting factors, platelets, and the coagulation factors, everything is diluted in the blood, which causes also with massive infusions, we'll see hypothermia and acidosis, also low calcium levels. So as a result of massive transfusion, all of this happens. The clotting factor, platelets, calciums level, etc. will reduce, which affects the coagulation. So even though after giving multiple transfusion, the patient is still bleeding, that means their coagulation pathway is affected as a result of dilution or large volume. So lab findings of this is increased PT, INR, PTT, all the times will be elevated, all the counts will be reduced. Platelet count, fibrinogen, calcium, etc. will be reduced, and the patient could be in metabolic acidosis. Um, Also, with this hypothermia, it also impairs the internal equilibrium in the body. The core temperatures reduce, which affects the enzyme activity. So all of this contribute to coagulopathies. And we'll learn about transfusion reactions in the next PowerPoint. So, when a patient is receiving massive transfusion, they are developing oozing at the blood site, prolonged PT-INR, falling platelet count. That means they might have been developing some massive transfusion-associated coagulopathies. And then sometimes, though, instead of just giving blood, we sometimes give plasma, platelets, or other components of blood too. So that's about that condition. One last condition in this is low platelets or thrombocytopenia. So thrombocytopenia means when the platelet count is below 150. There are three different categories. Almost the management is the same except for heparin-induced thrombocytopenia. So immune-related thrombocytopenia can happen as an autoimmune disease. Thrombotic thrombocytopenia, which is very rare condition, you would never see that. And then the other type is heparin-induced. So thrombocytopenia basically means reduced platelet counts. It can cause bleeding. So it can cause bleeding anywhere into the joint, retina, brain, cerebral hemorrhage, etc. As we know, when the platelet count is low, it causes the RBCs to leak out of the blood vessels into the skin. So that is what causes that little patchy red spots on the skin called petechiae. When numerous petechiae connect together, it becomes a purplish reddish color bruise called purpura. Then when there is hemorrhage under the skin, we call it ecchymosis. So that is the different terminologies which we use. Let's look at one more thing. When you work as a nurse, if your patient's platelet count is less than 50, you should not be giving them any of the anticoagulation. You should get an order to hold it. Because one thing to look at when we are administering anticoagulation treatment is to look at their platelet count. And most of the facilities would say if it's below 50, hold it or something like that. There could be an automatic order. If not, watch for the platelet count before administering any anticoagulation therapy. Other thing I want you to know is that the platelet count itself. So ORBCON or Ontario Blood Bank dictates the parameters for transfusion. Usually they say if the platelet count is 10 or below, do platelet transfusion. That is not like set in stone. Usually patients with low platelet counts, if they have bleeding or something like that, we definitely would give them platelet transfusion. But as per their guidelines, it is 10 or below, they should get platelet transfusion. Not set in stone. You don't have to wait until it's 10. If they have platelet count 30 and they are having hematuria or any signs of bleeding, we might administer platelet. But it's just a guideline set by blood bank so that we don't use and misuse the blood products. So then test for each of this type. So antigen antibody reaction is immune thrombocytopenic purpura. You can see that there are antibodies or specific assays. When we do that, you can see antigen antibody complexes in the blood. If it's heparin-induced thrombocytopenia, we do this PF4 heparin test. Then we can diagnose that hit. We're going to look at each one of them in detail. So as I said, thrombotic thrombocytopenia seen in like 1 in 1 million people or something like that. It's very rare condition characterized by hemolytic anemia and thrombocytopenia, which causes all these bleeding, neurologic problems, patient could also be febrile, and then renal ischemia. All of this can lead to manifestations. It is because of the deficiency of an enzyme. So, as a result of that deficiency of enzyme, the platelets will clump together in smaller blood vessels and eventually it get destroyed. So it forms a thrombosis and eventually fibrinolysis happens. So platelets are then broken down. As a result, it lead to thrombocytopenia. And as I said, it's a very rare condition. Um, Something to look for is clots and bleeding at the same time. The management for almost all of thrombocytopenic purpura is the same because plasmapheresis or plasma exchange is one of the management. That means they would have a central catheter called a Hickman's catheter, and then we exchange the plasma. We take the plasma with either the antibodies or like deficiency or heparin-induced thrombocytopenia. Also, we do plasmapheresis. We take that away and replace it with fresh plasma or without the antibodies. High-dose corticosteroids and immunosuppressive therapy are indicated in this. Rituximab, which is immune therapy. Splenectomy. Spleen is the organ which destroys the platelets. So splenectomy can increase the lifespan of the platelets. So these are the treatment. And when you look at the treatment, all three types almost have the same type of treatment. In ITP, what we see is that our body develops antiplatelet antibodies. These antibodies get attached to the platelet and then it destroys the platelets. So that is the pathology behind that. It's an autoimmune disease. So our normal lifespan of platelet is 8 to 10 days. In case of ITP, when it's coated with antibodies, the survival time reduces to 1 to 3 days. So that means platelets are getting destroyed at an alarming speed. Again, treatment is the same. If you look at that, you see that almost all this type of thrombocytopenia, they use the same type of treatment protocol, like steroids. In this case, we can give IVIG, which is immune globulin, to act against those antibodies, anti-D, tranexamic acid to prevent bleeding, splenectomy, again, to reduce the destruction of platelet transfusions, immunosuppressive therapies like rituximab and cyclophosphamide. All of this is the same modality of treatment. Now, this is a different type of thrombocytopenia, heparin-induced thrombocytopenia. So, very rarely, less than 5% of the clients who are on heparin therapy develop HIT or heparin-induced thrombocytopenia. That's why, remember we said the central lines were flushed with, what do we call, heparin in the earlier days, and now we don't, because now most of the catheters like dialysis catheter, permacath, is locked with sodium citrate solution. Hickman's are patients who are waiting for a transplantation, stem cell transplant or any islet cell transplant. They might have this, or they have this pheresis catheter called Hickman's catheter. It's a type of central line. Usually they lock it with something called kite lock, which is a EDTA solution. So we're looking at different other type of locks now, because the heparin can cause, in the long run, it can cause heparin-induced thrombocytopenia. Keep that in mind. People don't develop this condition that often, but when they develop it, the mortality is about 50 to 60%. So they have high mortality rate if they ever develop this condition. That's one of the reasons we are staying away from heparin, and sometimes we just use our good old normosaline to lock the lines now. So what were we talking about? This causes venous thrombosis, DVT, pulmonary embolism, etc. when a patient develops HIT. it become really tricky to treat. So again, the treatment is stopping heparin. The patient probably will have on their chart, like with their allergies, it might say patient has heparin-induced thrombocytopenia, so do not use heparin for this patient. Bleeding and um, other clinical manifestations are same as that of low platelet count. So it's easy to learn. Just learn it for one condition, then you can apply it for all of others. So what do we do here? Discontinue heparin, direct thrombin inhibitor, like certain inhibitors are used available that's used to cause prevent heparin-induced thrombocytopenia, plasmapheresis. Long-term use, we don't use heparin, we use medications like Coumadin for anticoagulation. That is the reason why we don't use heparin in the long term. So that's about that condition. I think that with that, we come to the end of this session. One of the biggest things is that if your patient has low platelets, IM injections should be avoided. That's your critical thinking. That can cause hematoma and other complications. So I want you to go through this summary and review it by yourself. This is the end of this acquired and inherited coagulopathies.